are mostly students who are logging in. Many of them are MD students, many of them are post-MD students, and they shall really benefit from understanding the basics of proton beam. Sir, I invite you to start your discourse, please.
Dr. Shubham Garg, Geeta, Gagan, and all, and I would like to congratulate you for this wonderful, wonderful initiative. I am most impressed by the work that you have done and are doing. I believe it is the 5th in the series, and this is what is needed. I begin with the current unprecedented times that we have, and I have a favorite quote that the optimist, waits for the wind to change. The pessimist is always thinking, what shall we do? And the leader actually adjusts its sails. So you have adjusted the sails beautifully from the educational point of view, and it is my honor to be able to contribute in my own little way to this fantastic educational exercise. Your questions were apt, Gagan, and very technical and very appropriate from both scientific and physics part of it. And I try to combine both the physics, and I realize that many of them are clinically oriented. So I'll try to pitch in some of the clinical data for this exciting field. I'm going to begin though with a slide. I hope I'm trying to get the next slide. Pankaj, can you just help? Bear with me for a minute, please. Okay. I'm going to start with this fascinating data, which many of you may have already seen. This was a collaborative effort from 5 continents around the world. We call it PURE study. It was basically a prospective urban-rural epidemiological study. And it was prospective. It was originated, the data was collected in Canada, and was fascinating because this, for the first time, showed an epidemiological transition of the non-communicable diseases. And it showed that among the various NCDs, which is cardiovascular, MI, stroke, heart failure, chronic obstructive pulmonary disease, injury, pneumonia, and so on and so forth, that cancer is very likely to become the common cause of death globally in a few decades. And in many parts of the world, especially in the lower income countries and certainly in the high income countries, already cancer has overtaken cardiovascular disease in many forums. So this is a sobering thought, and therefore whatever we have to do for this cancer is becoming a public health hazard, as we already know in the last few years, and it is unlikely that it is going to go away very soon. At the same time, however, we are encouraged by the fact that depending upon several epidemiological studies that we have done, the screening, the actual treatments that we have, whether it is form of surgical excision, the systemic therapies, radiation, and so on and so forth, it has been estimated that about half of these cancer patients may actually survive for more than 10 years. Most of the student population, we still say that kind of 5-year survival is a goalpost which we try to achieve. But many of us believe that some of these cancer survivors, we have to wait for 10 or if not more than 10 years. So I do believe among those people that we have to extend the goalpost to about 10 years survival. And both the overall survival and also the freedom from progression is an important endpoint. But we also have to temper with this growing evidence that although we have long-term cancer survivors, we also are grappled with the fact that it is not only the survivorship which is important, it is equally, if not more, also important than how are these survivors doing in their day-to-day life. We know that data from childhood cancer survivor study, because we know that childhood cancer survivorship is close to 65 to even 85 to 90% in different parts of the globe, whether it is total survivors, the hematological malignancies, the CNS tumors, and other extracranial childhood tumors. But we know that about 2/3 of them would have either a chronic medical issue, and a quarter of them can actually have a severe life-threatening issue. And this was published a few years ago in the New England Journal of Medicine from the childhood cancer survivor study. Now the data is actually for 20,000 people, but the data is more or less the same. Those who are more akin to the adult oncology, we also realize that in several curable diseases like hematological malignancies, like Hodgkin's, but even in breast cancer, because of systemic therapies, radiation, especially on the left side, in various sites of where there are issues of lymph salvage, in head and neck cancers, how critical it is to preserve the larynx and the swallowing function. The functional outcome is equally important: chewing, speech, gait, activities of daily living, and so on and so forth. In the last few years, though, there has been an increasing emphasis on the enhanced surgical skill and technology plays a role as well, whether it is minimal invasive surgery, whether it is laparoscopy, whether it is robotics, and so on and so forth. We all know what a great impact personalized medicine in terms of molecular signature driven therapy has played. And to see the genetic and molecular signature of each tumor, we know that each tumor is different, each patient is different. Both the phenotype as well as the genotype of that patient would make a difference. And therefore, the emphasis on personalized approach, whether it is systemic therapy, but has also given rise to other forms of treatment like immunotherapy and immuno-oncology. But it also brings to the fore the impact of high precision radiation. For example, proton, but it also can be high precision photon and also can be other heavy charged particles. The ultimate aim for all the oncology colleagues, and many of you are just beginning the career, is to find that fine balance, is to evolve a paradigm, is to find a principle and the protocol of every single patient right from day one, to find the balance which would achieve the very high chance of long-term survival and cure, and balance it vis-a-vis with high quality of survivorship, what we call quality of cure. So cure and quality of cure. So you have to find that balance between the two. And some of these approaches, as I mentioned, are tuned at the moment in different parts of the world towards finding this balance. As far as radiation is concerned, many of you are already knowing it is very important to achieve local control of the cancer. To some extent, in many sites, it was thought that radiation may achieve local control, but may not have impact on overall survival. But we know now in different parts, in breast cancer, in head and neck, and many other sites, about a significant proportion of the cancer patients, the radiation therapy is an extremely integral component and not only achieves local control, but also is a very important loco-regional disease. In fact, whether it is a complete excision of the tumor, but the stage and even the molecular and genetic profile is such that there's a relatively high risk of loco-regional failure. There you employ either alone or frequently these days, along with other therapies, whether local therapy with surgery, but also with systemic therapy, both the chemotherapy, the targeted therapy, immunotherapy, so on and so forth, either concurrently, neoadjuvantly, and or after post-treatment. So radiation is a form of what is called combination multimodality therapy. And it's been estimated that's about 60 to even 70%. There is a difference a little bit in different parts of the globe. In some parts of the Western hemisphere, the figure is about 50 to 55 to 60%, because many of these cancer patients are sometimes seen in very early stage, either pre-invasive or stage 1 or early stage 2, where a radical form of therapy, for example, surgery alone. And the classic examples could be early prostate cancer, early sometimes breast cancer, or head and neck cancer, or GI cancer. You don't need radiation therapy. But in many parts of the world, and we now know that in developing world, the 70% of the cancer burden throughout the world actually is in developing world, including countries like India, where we do still get the cancers like head and neck, breast, cervix is unfortunately still not so uncommon. It's still the second commonest cancer in women, and many other sites where radiation plays an important component. And we know now radiation, how it works. It's a local therapy. It is the free radicals and the photon. Traditionally, most of the action is indirect because of the free radicals, and therefore it fixes what we call fixing the DNA, and is dependent upon oxygen. The charged particles, which we will realize in the next few slides, is not form of the electromagnetic spectrum where the conventional X-rays or photons work, speed of the light, and they have characteristic inherent properties. And there, the charged particles can also have a direct DNA damage and can what's also called direct action. So it has both indirect action as well as the direct action. And classically, this has been the photon or X-ray therapy has been delivered by linear accelerators. I just want to show you this slide, and this was when I was a student. We used to treat sometimes with cobalt or a very modest, very early linear accelerator treatment where this was the target, this was the critical structure. You could treat it with parallel pairs, sometimes even with 2-3 fields. Gives a good distribution to the target, but it gives unfortunately very high dose to a critical structure as well. And then if you became more sophisticated, we did multiple therapies, sometimes used 3D conformal therapy, and also went on to have intensity modulated radiotherapy, which is perhaps the standard of care at the moment. And you can see the sculpting of the doses to the critical structure with sparing of the normal tissue. And in the modern current era of either fixed field or what we call volumetric R therapy, which is commonly employed as a modality to treat photon radiotherapy, gives a beautiful dose distribution to the target, spares the normal tissue significantly. But mind you, still there is some dose to the organ at risk with significant what we call low to intermediate dose wash. And that can also be a problem. So what you do essentially, if you compare like this, although there is a high dose envelope to the tumor, but also to the surrounding tissues, to a thick slab of normal tissue, this you are sculpting the dosage to the surrounding structures, but you actually distribute this heavy dose or high intensity dose to a low or intermediate dose wash to a significant amount of normal tissue. In radiation oncology, we call it integral dose. So this was one of the questions also, that with photon, highest form of photon therapy, you distribute dose, this dose, integral dose is relatively high. And sometimes some of the late-term survivorship issues can also happen in low and intermediate dose in different parts. And obviously in children and younger patients or those who have more long-term survival and breast cancer, heart, and there are many, many examples which I will explain to you in the next few slides, which could be a potential source of improvement if there is a improved technology which can yield as beautiful dose distribution conforming to the target and yet get rid of this low and intermediate dose wash. Why not it? And let us see whether we can achieve that at all or not. Now, proton, as was mentioned, is actually a charged particle, and we use hydrogen. We use a pure hydrogen gas. We take out the electron out of it, and I'm just trying to address some of the questions which Dr. Sani had put up in the slides. And you can't change it, unfortunately, because I believe you must have sent it already to the WhatsApp. But nevertheless, so when you take out the electron out of it, then you get this proton. Now, traditionally, when the proton therapy was started, and surprisingly, it is not so new, although it is relatively new from the clinical practice, but conceptually, Robert Wilson was among the first ones way back in 70 years ago. So what happens is that you have the conventional X-rays like this, they enter to the tissue and they have this classical dose fall off, while the protons, they have a lower entrance dose as compared to the conventional X-rays. And protons are actually light, they are not very heavy charge. So these protons are like relatively light. So after a finite distance in the tissue, they just give away all the energy, all the intensity at one spot or one at point. And that is that we achieve what is the classic Bragg peak, and deposits all the energy there. And since all the energy is deposited, then you have this classic, what I call classic waterfall, with literally no dose whatsoever. In our radiation oncology parlance, we would say to our student, is zero dose beyond the target or tumor achievable? It was not possible, because there will be always a little bit of dose always at the end of the spectrum. But in protons, actually, it is possible to just limit the dose whatsoever to the surrounding tissues beyond the particular where you intend the proton beams to stop. Now, this is how the basic physics of proton is. And the hospital, Weiss Loma Linda, was among the first ones in California with University of Berkeley, which started the experiments. Then it was Uppsala in Sweden. and then PSI in Zurich, and Japanese centers and many other centers in Mass General in the United States as well. They started building up these cyclotrons and synchrocyclotrons to have protons and other heavy charged articles as well. But was what also mentioned that although this gives this classic Bragg peak, but unfortunately the tumors are not pinpoint peaks like that. They have a definite finite size. So in order to do that, what we do is we degrade the energy of the beam. So the highest energy would be at the end of the proton beam. And we put different foils such that you can degrade the energy. And therefore, the proton peaks, the Bragg peaks, will be accumulated over a certain distance or a certain parameter. And that's why it's called spread out Bragg peak. So what happens is, as you can notice from here, you can actually treat a larger amount of tissue. The fall off is still very steep and very nice, although at the end there is a slightly higher dose, but still much better than photon. But mind you, the entrance dose is slightly higher. So at the risk of having a slightly higher entrance dose with multiple energies, the spread out Bragg peak can still give a fantastic dose distribution, and you can still achieve this waterfall where there is very little dose beyond the tumor. So the ability of the radiation oncology and medical physics is such that you devise your radiation plays in such a way that these Bragg peaks are delivered in such a way that you conform the proton beam along the shape of the tumor or the target, as we say, which includes the microscopic extension of the tumor, and try to limit the radiation dose, especially the low, not only the high dose envelope, but also the low and intermediate dose envelope, significantly better than we have with the photons. Now, to do it was relatively cumbersome. We had what was called passive scatter technique, which was also mentioned in the quiz. So what we had was, because it was, if I have to explain in a very simple manner, the beam was like a torch. You have a torch beam and then you shine the beam. So you get a V type of a torch. But as you know, the tumors are not like torches or not like circular. So what we had to do was we had to keep different scatterers in between. And then we had to use a combination of apertures and compensators. And I've seen, the first time I went saw the proton beam was in 2005 in Chiba in Japan. And there I saw robots actually making these different compensators. And this yielded a technique called passive scanning or passive scatter. It was quite cumbersome. It needed a workshop, additional manpower, a lot of hardware. Because you had the hardware, unfortunately, although you had the advantage of the proton beam, it actually also resulted what is called neutrons. And neutron contamination is not good. It can actually produce a lot of side effects, including more cancers. And this was a major issue with the earlier generation protons. And although the technology was there, because of different factors, it did become popular. Added to it also was a relatively cumbersome modality. It was almost the whole paraphernalia which was employed to deliver this proton beam almost reminds you in a joking manner like a 1970s, 1980s Star Trek type of environment. You know, you have all the contraptions, the fixed beam. This is, by the way, a melanoma of the eye, which was among the first ones to be treated because it was a pinpoint accurate treatment, but you needed very small energy to treat, and you didn't need very too much of the spread out Bragg peak. And this was employed in different centers. The indications were relatively small. The revolution, if I may say, or some people may say evolution of the technology took place about nearly now close to, the first paper came actually in 99, 2000. It's almost 20 years ago, but you know, by the time it comes to the clinic, it takes several 8, 10 years. It's like a phase 1, phase 2 study of a new molecule. And by the time you reach into the clinic, it's always so much time. So it is very, very important to differentiate a proton beam with a proton beam. And just like you have a proton beam has very little meaning, you have to be very careful to differentiate what proton beam is currently employed in that center or in that facility. So I like to spend a minute or two on this because this is an extremely important concept by physics point of view, which I would like to explain to you. What is called the modern contemporary proton beam. So the modern contemporary proton beam is a pencil beam. It is not like a torch now. It is like a small pencil, and the pencil could be like a laser pointer that you have in your presentation. So compared to a big beam, there is a relatively small pencil. So what this pencil does is, because it is a finite and the spot size can be very small, it can be 3 millimeter, 6 millimeter. I have a slide later on the spot impact of spot size. So it's a tiny spot. So one revolution was that from the passive scattering technology, we became to active scanning, or what is called pencil scanning, pencil beam technology. So you have a finite small pencil beam. The second thing which came was the energy of the beam increased. Previously, we had limitation. We had only relatively few energies available in the clinical practice, and you could not treat very deep-seated tumors. Now the energy is as high as 230 to 240 MeV, and the lowest can be 70 MeV. We call it million electron volts, MeV, such that whatever is the normal human body in any part of the world, whether it is a superficial tumor or the deep most seated tumor in the abdomen or the pelvis or the liver, or a retroperitoneal sarcoma, or the spine and the brain, wherever, whichever site you name it, it can be encompassed with the, for example, in our center in Chennai, which is again, we are very happy to state that in India, we have really the state of the art pencil beam technology, which has a range from 70 MeV to as high as 230 MeV. So you can treat practically the whole range, number one. And number two is, it is all pencil beam. We do not have any passive scattering. We have a pencil beam technology. And what it is you select whatever energy the maximum energy is at the latest. So you divide the target into different slices. And what we treat, and the laser beam, this different point, the pencil beam, with the very sophisticated algorithms, you can actually paint literally the tumor. It can go point by point, line by line, and layer by layer. It is like you slice, like a bread slice, loaves. A loaf can be sliced. So it goes through the energy, the farthest energy goes to the first layer, and then it keeps on going proximally. And the last layer is the minimum energy. And the computer does it for you, actually. And therefore, that is the second revolution would take place. There are two more extra things which took place. The two things took place was the pencil beam and the energy. Two other things took place was, although we had this sophisticated technology, it is amazing that a significant proportion of proton beams, including today in many parts of the world, do not have image guidance. You may have the most fantastic technology. You may have a very good planning system, a computer which actually calculates the doses and optimize the beams and helps in delivery of the treatment. But if you do not have a handle whether you have actually positioned the patient accurately, and you make sure that the beam actually goes to the intended target, you actually lose the whole concept. And therefore, many of the proton beams did not have what is called, which is very standard in any photon technology. And I must admit, there was also a little bit of a historical problem, because the proton physics teams were working little bit in silo, and they were compartmentalized between the photon physicist or the photon radiation oncologist and the proton. In the last 10, 12 years, there has been a synergy, and many of the radiation oncology and physics teams have migrated to proton and vice versa, including, for example, myself. I have cut my teeth and spent 25 years in photon, and now only in the last 3 years, I have now switched over to protons. And I can see the difference, what we can bring to both the technologies. So you have now best of both worlds. So nowadays, every single modern proton beam therapy has an inbuilt cone beam CT, three-dimensional picture can be made, and what we call image guidance, which is actually fundamental in any modern photon beam, X-ray, which is the conventional linear accelerator, and that has been brought. So you must realize, you'll be amazed, some of the finest centers in the world, including well-known centers, still do not have image guidance. And finally, two small more things. Many of the proton machines had a limitation of the movement of the gantry. It is a very, very heavy gantry. It weighs about 110 to 120 tons. And if you look at the back of the gantry, it is as tall as about 2 to 3 stories. It's an overwhelming sight. And I welcome many of you who are willing, and after this pandemic is over, when you're able to travel, you're more than welcome to visit our facility, and we will be delighted to show you how it works. And if you go at the back of the gantry, such that the gantry was not able to move. The couch was not robotic, it was not so accurate. So the modern proton beam has a very fantastic with 6-degree rotation couch, which is very accurate. We also have a Leone robotic couch. We have two gantries which move 360 degrees, and it gives you lot of freedom to plan your treatment non-coplanar as well, such that you get very nice dose distribution, and yet you have the cone beam CT as well. And finally, all this has to come on a physics platform. So you need a very robust physics treatment planning systems. And again, you must see these are small, tiny things that are very, very important. And we are, again, very proud and delighted to say we have one of the finest treatment planning systems, especially customized for proton therapy, which is called RayStation. It's a Scandinavian company which just makes only the planning systems. Mostly they are known, they're USPs to make the planning systems. And we have the RayStation to plan the therapies, and also use very sophisticated what we call Monte Carlo algorithms, not only for our optimization but also for planning and for calculation. So most of the people use calculation, and we have treated now almost 200 odd patients, but we have insisted that every single patient is treated with or optimized by Monte Carlo optimization. It takes a little bit more time. This is mainly for my radiation oncology colleagues to emphasize that how important is to put all these processes in place such that you can achieve the best of the technology can offer, ultimately, of course, help the treatment plans and help our families. Because of these advantages and these transitions and these evolutions and the incorporation of the different sophisticated things that have taken place, you can see the graph how the operating particle therapy centers in the world have kind of escalated, especially in the last few years. And we have now treated more than 200,000 worldwide, and a very large number of the patients are being treated in different parts of the world. Because of the pencil beam, because of the 360-degree rotation gantry, because of the 6-degree freedom robotic table, large fields we can treat even moving targets, motion management. We can also adapt our treatment if there's a weight loss or there's a shrinkage of the tumor. Every week we can see the planning system, and if we have to adapt, what is called adaptive radiotherapy and image guided radiotherapy is very much possible. So the classic indications, which were relatively few indications only with the older generation of proton, is literally every day expanding to different sites, including liver cancer, head and neck, lung, breast, different GI cancers, pelvic tumors, sarcomas, prostate, mediastinal tumors, re-radiation. I will touch upon briefly on each clinical site to give you a sense as to how this technology can be applicable to different cancer sites during radiation. And I would like to begin by showing you a case, which was the first case to be treated in India, a childhood brain tumor. It was an 8-year-old child who actually had a cellular supracellular tumor. This is called a craniopharyngioma. It's not an uncommon tumor. You try to operate upon these, but many times they are stuck to the infundibular stalk. Vision is impacted. That's what we were doing, and we were observing that this child eventually it grew and there was significant residual, and this was an ideal case for proton beam therapy. Immobilization is extremely important. Many of our patients need anesthesia, and you have to have those things organized in your center. The target dose is what is called 50 cobalt gray equivalent because it's a charged particle. You have to do thin slices CT scan. You always do an MRI, T1 contrast, and T2 flare. Some of the interesting things which some of my radiation oncology, even the other oncology colleagues will find it interesting, that we go back like 20 years ago. And I remember before the VMAT era, especially, or before IMRT era, when we had the 3D CRT or forward planning systems, we did not have inverse planning. We used to spend hours and hours and days to see what kind of field arrangements can we employ. Should we put a vertical field? Should we put a non-coplanar field? Should we put a field which will not go through a critical structure, what is called class solutions? And this is kind of revisiting the whole thing. You have to be very conscious that proton beam per se also introduces some uncertainty. And what are the uncertainties? Because it is a charged particle, any change in density, whether even as change in density, whether it is a bone or a little bit of mucus in the nasal cavity or in the sinuses, a little bit perturbation of the fluid, any metal as simple as a VP shunt, for example, a shunt tube or a extra ventricular drain can completely perturb the dose of proton because it is dependent upon the density being a charged particle. The photon doesn't have so much a perturbation of the dose. So this is all incorporated into the planning system, of course, because we are very conscious about the density, but also brings in inhomogeneity and uncertainty. So it is, we spend so much time, what is called pre-planning audit, as to when we make the mask and when we decide what field arrangement has to be there, we recognize that what are the beams that are likely to go through, not only to encompass the target volume, but also to avoid any structure which might cause perturbation of the dose and can decrease and can introduce higher degree of uncertainty in the proton distribution within the target volume. And also what it adds to the uncertainty, therefore we do what we call planning CTs and quality assurance CT scans and MRIs 3 to 4 sometimes during the treatment to look at the image guidance, but also to see whether any change of the density. In head and neck cancers in particular, and sometimes in brain, but also in pelvic tumors, any change in gas, any change in distension of the rectum, for example, in prostate, uh, will cause a perturbation of the dose and can have potential changes which may not be so much relevant in the photon world, but has huge implications in the proton world. And over a period of time, there's a bit of a learning curve. Fortunately, the proton world is a very closely guarded, very close group, and there's a lot of exchange between the various systems, and we learn from each other. And these are incorporated in your, and that is, it's a very process oriented plan. So you have to follow the process very religiously with relatively tight thresholds. If you exceed the threshold, you have to redo the whole thing. And that is why proton does take a fair bit of toll. The planning also takes a little bit more time, and you need a lot of hard work and the collaboration between your physics teams and the oncology team, and also the treatment delivery team by your radiation therapists. And these are all, you have to all come into that place. Now, for example, if this finally we chose a distribution which gave the best distribution of the dose, we have a tomotherapy machine also in our setup, and we have excellent tomotherapy planners as well. And which is, tomotherapy is a VMAT technology, is one of the finest photon technology, and we compare always the plan with Tomo, and you can see very beautiful dose distribution. The most important dose here was the hippocampus, and I'll come in a minute why hippocampus is important. And the hippocampus dose was exceedingly low as compared to photon, literally 50% of the dose which you would have otherwise treated, and the temporal lobe, because this child has like 90 to 95% long-term survival rate. In my previous institution, Tata Memorial, we had a prospective study in craniopharyngioma where we showed 7-year prospective data of 95% survival. So this child is going to live forever. So every single tissue or every single millimeter or centimeter of the normal tissue, especially the hippocampus, temporal lobe, the integral dose, the optic chiasm, and so on and so forth, are important to save. And therefore, this was a very good case for pencil beam, IMPT, and image guidance. And as has been seen, craniopharyngioma is a very important indication for proton therapy. In my previous institution, we have already shown the importance of left temporal lobe to be a predictor of neurocognitive decline. And this can be much easier, obviously, if the dose distribution is so tight and conformal without compromising the tumor dose. Naturally, this has a very good indication for reducing the doses to the temporal lobes. In my previous institution, but this paper was published like last 2-3 months ago. This is the first time ever somebody has collected prospective neurocognitive data from baseline before you start radiation up to 5 years. This is not a proton data. This is a stereotactic conformal radiotherapy data with photons, but is among the first ones and the only ones in the world which have shown what could be the potential dose constraint to the hippocampus to predict neurocognitive dysfunction over a period of 5 years. There are many centers in focal radiotherapy. There is a lot of data in whole brain radiotherapy for brain metastasis, but very little data with focal radiotherapy for low grade and benign tumors. And we could demonstrate that about 30 gray or so is the mean dose to the left hippocampus to preserve intelligence in many of these young children. And this can be very nicely incorporated routine clinical practice. And many a times we can achieve it in photon, but sometimes in a larger tumor, in a complex tumor, in a different anatomy, protons will achieve much, much better data than the photons, as we have seen in many other sites. Therefore, also is the indication for another common cellular tumor, the pituitary adenoma. Sometimes we have to treat radiation. If there is a residual tumor, there's a progressive tumor in a functioning adenoma where you do photons, proton can achieve significantly superior dosimetry to the temporal lobes and to the hippocampus as compared to radiation therapy. It has been also extrapolated now to low-grade gliomas. This was a low-grade glioma we treated in our center. It was among the first cases we treated about a year and a half ago. It was a favorable low-grade glioma molecularly, but in a very difficult site. It was in the corpus callosum. Only a biopsy could be possible because we cannot operate. It was otherwise a fit, very clinically, and actually a high-profile gentleman who had fortunately IDH mutant, 1p19q co-deleted, and also TERT mutant tumor, which is actually an oligodendroglioma. They have a exceedingly good result. Even the anaplastic oligos with favorable molecular profile, the median survival is exceeding more than 15 to 17 years. So it's important to preserve the normal function. And we treated with photon therapy with IMPT. Not only we got a very good tumor response, you can see significant resolution of the tumor, but also we could spare his hippocampus, and he is leading an excellent cognitive and daily activities of daily living in this particular gentleman. And the NRG in the United States, of course, is utilizing this technology to generate a high level of evidence in a phase 2 randomized trial of proton therapy, the modern proton therapy using intensity modulated proton therapy, comparing with the best photon technology, which is the intensity modulated radiotherapy, which is the photon, and randomizing them to the two arms with favorable profile, IDH1 mutant, WHO grade 2 or grade 2, who have a long-term survival, choosing a very relevant endpoint of neurocognitive function and patient-reported outcomes at 6 months and yearly. And we are eagerly looking forward for this trial to show us whether protons would make a difference. Some of you may be already aware the study that I was fortunate enough to lead in my, again, previous institution, where we could manage to generate, again, a level 1 evidence in a similar criteria, but we didn't have proton that time. That was the photon, but comparing the conventional photon, the conventional ones that we use, comparing with the high-end photon technology of stereotactic conformal radiotherapy. And we chose, again, a clinically relevant endpoint of neurocognition and neuroendocrine function with 5-year survival exceeding 90%. So this has been published. Many people have already seen this data, but the only point I want to make that there is always a challenge for surgery and radiation to generate level 1 evidence. And as compared to pharma studies, it's very difficult to randomize these patients. But this is among the few studies where we could generate basically an evidence that smaller volume of irradiated normal tissue does equate into significantly superior clinically relevant endpoints, taking very hard endpoints and very relevant endpoints of cognition and endocrine without compromising the local control and survival. And therefore, this can act as a benchmark for further studies as well, and so on and so forth. Also, in continuing with the theme of childhood and curable cancers, the craniospinal radiation, my radiation oncology colleagues will bear with me, is one of the most complex radiation planning in any form, because you have to treat the whole cranium, whole spine. What happens is there is significant doses to the anterior structures, and proton is actually the main treatment which gives fantastic results. So what happens is it can treat the brain, it can treat the spine with literally no doses to the thyroid, to the heart, to the lungs, to the kidneys, to the liver, to the bowel, to the gonads, both the testes and the ovaries, depending upon what the sex of the child, gender of the child is, and has become the standard of care. And this is relatively complex in proton field also, but this is one of the children that we treated in our own center. We have treated quite a few now, and this manuscript we are actually under the review, and you can see very elegant dose distribution, treating the spine and the cranium with literally very, very little dose. In an older child, where the vertebra have fused already, you can actually spare significant amount of anterior vertebral body and can have benefit in terms of lesser hematological toxicity if you have to combine with chemotherapy, which is the case in many such children. Has been already demonstrated in many studies. This was a work on a phase 2 single arm study from Boston, again showed very good data, and also significant reduction of the low doses, but also other clinically relevant endpoints, significant less doses to the cochlea, which can have an impact on hearing, particularly because many of these patients need cisplatinum or platinum-based therapy, which all of us know can have impact on the cochlea, and also significantly less doses to the heart, and has become the standard of care. But what was amazing was this work, which was published like 6-8 months now ago in JCO, that even I was a skeptic that although it could reduce the doses, the protons could reduce as compared to photons or external beam radiotherapy. This is 37 patient data, not non-randomized, mind you, compared to a matched cohort analysis treated with external beam radiation. And we thought that the proton has to treat the whole cranium and whole brain, so there could not be any improvement in the neurocognitive. You can have improvement in other structures like the thyroid function, the cardiac function, the kidney function, and gonadal function, and the spine and the height. But how can it be different in the intellectual function? And so it was a bit of a surprise to people in neuro-oncology that they showed that was actually an improvement in neurocognitive function too. And people have tried to tease the data. We still do not know what could be the possible reason. One of the reasons postulated is in medulloblastomas, which is one of the key tumors to be treated with craniospinal radiation. You have to treat CSI followed by tumor bed boost. Or when you do tumor bed boost, when compared from X-ray treatment, proton may actually give lesser dosage to the temporal lobe and to the hippocampi, particularly the posterior, the tail of the hippocampus, and that could possibly yield superior intellectual outcomes. I have to say this is very intriguing and very exciting and fascinating data, but has to be tested and validated in a prospective cohort fashion. And hopefully, if we can show, some of the groups can show, this again gives credence to otherwise hitherto thought that this was not a valid endpoint to reduce the intellectual outcome with protons, but can be shown there as well. And as I mentioned, in older children, you can actually spare the bones as well. We also have realized that this was the data present, and we published it last year from a previous institution again, that what could be the dose constant to the pituitary hypothalamic axis. And this was again the data for 27 gray. And many centers in the world have compared proton and photon radiotherapy in various sites and have demonstrated again the reduced need for endocrine therapy, which is very, very important, and greater heights have been demonstrated both in hypothyroidism, sex hormone deficiency, and many hormonal excesses. We had less dependence and less replacement therapy when you employed proton as compared to photon. And therefore, in pediatric cancers, not only in brain tumors, but in extracranial tumors like Ewing sarcoma, sacral, rhabdomyosarcoma, orbital tumors, now the proton therapy is the standard of care. This was one of the youngest children we treated, 3-year child. Today, in fact, we completed the youngest child treated in India, which was 16-month-old child for a posterior fossa ependymoma. In young children less than 3 in ependymomas now, even photon therapy is applicable. Not necessarily the 3-year used to be the cutoff point. And that was just today on Doctor's Day. It was just coincidence that he finished the treatment today. But this particular child had a pelvic rhabdomyosarcoma and had to be treated after neoadjuvant chemotherapy with proton. And you can see proton resulted a very nice distribution. Dr. Srinivas, my colleague, who actually is a pediatric radiation oncologist, could demonstrate that you could reduce significant amount of doses to the surrounding structures, to the testes, for example, here, to the bones, to the femoral heads, to the growth plates. And these are all relevant from long-term cure rate and as well as the quality of cure. Many people also say that in extremity proton therapies, the growth plate can be spared, and therefore in those sarcomas also proton can be used. Many centers in the world, this is an example from Scandinavia, which have shown these are the group of patients which have changed their practice from a photon world to a proton world. And you can see vast majority of the childhood cancers, both brain and non-brain, have switched over from photon and is the standard of care now with proton. And this has been emulated by various structures. various centers in the world and cooperative groups. One of the significant advantages, which was again a question in the quiz, was the protons, because they have this reduction, significant reduction to the integral dose, especially with pencil beam, because you eliminate the neutron contamination, because there is no collimator, there is no aperture, there is no hardware. So you eliminate the neutron contamination, which was a little bit of an issue with the passive modulation. In the scanning technology, especially the pencil seam technology, the IMPT as we call it, has significantly, this is one singularly attractive advantage, and it is a very, very important advantage, because many long-term survivors, as low as 1 or 2% to about 30% of the long-term survivors, are at a risk of developing a second cancer in different sites, whether it is head and neck, whether it is breast, whether it is GI, whether it is children, whether it is in the brain. And significant proportion is because of radiation induced. There are other factors, there are genetic factors, there are systemic therapy factors, chemotherapy itself can cause, but a significant proportion is because of radiation, and at least that risk can be eliminated with modern protons. One of the classic indications of proton traditionally has been difficult to resect and difficult to irradiate skull-based tumors, both chondrosarcomas and chordomas. And this, even the passive scattering, was a useful indication, a classic indication for protons, because we have to give very high dose, as high as 72. We actually give now 76 Cray to these tumors. This was one of the treatments that we ourselves treated as a chondrosarcoma. You can see very dense chondrosarcoma here. She is a physician herself. It is in the pre-proton beam therapy, was operated already twice. There was a residual tumor. You can see post-proton, while the size may not have decreased, but you can see the central hypointensity showing a significant amount of necrosis and response to proton therapy, which is not so much seen in the photon world. Could be possibly because of higher RBE. Again, a quiz question of 1.1 to 1.2, which is the RBE, relative biological equivalence of proton as compared to photon dose to dose. And this could also be because of that, and the high dose that we can accomplish with proton therapy as compared to photon therapy. We also use surrogate endpoints like perfusion scans to show this, demonstrate this response. We have also seen several difficult to resect sacral tumors. This is another example of sacral tumor, which was significantly better treated with proton as compared to photons, and again yielded a very good result. Some of the treatments that we have also treated, this is again the proton therapy with skull-based tumors, but the benefit of pencil beam using a scanning technology and image guidance has further resulted in extra 20% improvement in survival and local control. The chondrosarcoma 7-year local control is more than 90%. Even in chordoma, which is a very difficult tumor, which keeps on coming back, the median follow-up, median survival was never going more than 40–50%. And now you can expect 5 to 7 year local control and survival exceeding 70 to 80%. Even with the proton evolution from passive to image guidance, pencil beam scanning technology, we have been able to demonstrate a superior outcome for these tumors. For atypical and anaplastic meningiomas, very difficult to treat. We can escalate the doses being studied in various cooperative groups. This was one of our own patients that we have treated. The American Society for Therapeutic Radiation Oncology, the ASTRO, now gives group 1 indication of ocular tumors, skull-based tumors, spinal tumors, liver cancer, and all childhood cancers. Also includes the genetic tumors where there are very risk of radiation-induced toxicity, both malignant and benign primary brain tumors, advanced head and neck cancers. Classically in head and neck cancers, the paranasal sinuses and the unilateral head and neck cancers in the oral cavity were classic indications of proton, and the salivary gland tumors as well, retroperitoneal sarcomas, and of course the re-radiation. The group 2 is the indication group where the technology is there, the evidence is being accumulated in. Already it has actually become group 1 in many sites, but in the next 3 or 4 years, based on the data, this is likely to be in the indication group as well, which includes even early head and neck cancers. Lung actually has become now number 2 indication in the United States for protons. Abdominal malignancies, pelvic malignancies, non-metastatic prostate cancer, and we will touch upon breast cancer as well. The proton facility, we are very grateful for Apollo to bring this proton facility in India. And I know at least in one or maybe two sites in India, this is being built, including Tata Memorial. We have 3-room technology, multi-room technology by IBA, which is the market leader in the world, has 60% of the share close to in the world, which is a Belgian-based company, one of the pioneers in the world. And the Tata Hospital project is also by IBA. So we have 2 gantries and 1 fixed room, out of which 2 gantries are operational at the moment. And these are the different technical parameters about the team. This is actually how the beam machine looks. Looks very, very, very patient friendly. And this is the couch, this is the nozzle, this is the patient positioning system, the couch top, monitors, and X-ray teams to look at the image guidance. We also have an Align RT surface guided radiotherapy and lasers to guide the beams. These are the different beam lines. The cyclotron is the one, this was another question, where you generate the protons, but the protons have to be put by, for example, in our setup, by 64 bipole and quadrupole magnets, which are called bending magnets, because you have to bend the beam, what is called beam transport system, and it is in vacuum. Otherwise, the protons will go here and there until they lead into the different 3 treatment rooms where they go into the gantry. And you can generate up to 230 if you want lesser energy. There are beam degraders which can produce whatever energy the treatment planning system does it for you during the optimization process. As I said, we are very close to reach the 200 mark because a lot of patients are under treatment at the moment. As one would expect, and actually that is appropriate as well, a significant proportion, about a quarter, belong to the pediatric subgroup. We have treated all sites, the brain tumors, the head and neck cancer, genitourinary, bone and soft tissue, thoracic, breast, and GI. Re-radiation, about 10 to 20% of the cancers, mainly in head and neck, brain, and many other sites, have to be re-radiated, and whenever there's a re-radiation, proton therapy is a treatment of choice. I like to show you one case which my colleague Dr. Nangia treated. This was an esthesioneuroblastoma young lady who was erstwhile treated with conventional radiation with photon few years ago. And we had an issue with sparing the only functional eye. She was already had significant impairment in the other vision. And we could manage, we generated a proton plan, and we generated also a very high precision tomotherapy plan. You can see the difference, the beautiful dose distribution of the proton that is needed for the control of the tumor. And if we had to achieve this, there was no way we could achieve with the tomotherapy plan. This was another advantage for this particular case for re-radiation. We have treated a number of head and neck cancers, and head and neck cancers is becoming an important indication as well. As I mentioned, both in the radical setting, post-operative adjuvant setting, with or without concurrent systemic therapy, especially in the ipsilateral side, the salivary gland tumors, nasopharynx, the base of skull tumors, the sinus tumors, and also the lateral border of the tongue, the buccal mucosa, the tonsils. The data for the thyroid and the larynx is a bit of iffy, although some work is going on because there is motion management. You can achieve equally good results perhaps with photon, but that data is not so robust. But all other sites, head and neck cancer has become very good. This is just an example to show you a very good tolerance with hardly any mucositis, which you would otherwise expect in a photon with hardly any loss of taste, which was not seen otherwise. And also depends upon several technical aspects. For example, the difference what the sharpness of the spot size makes, and we are lucky here to have as spot size less than 3 millimeters, and we can go up to 12 millimeters. It also has a difference in the dose distribution. We have 2 types of planning, and just a little bit of technical, just few seconds I will take. If you treat the active scanning, what is called single field optimization, it is akin to what is called 3D CRT in the conventional photon beam, that each beam delivers homogeneous dose to the target. And you have 3-4 fields. We don't need many fields in proton because the beam just stops. You need multiple beams in the photon world, like a VMAT, because you have to achieve that dose distribution, that fall off of the envelope, which you don't need in proton because just dose stops after a finite distance, as I showed you. So just 3-4 fields, but homogeneous dose distribution called single field optimization. it is more robust. The uncertainty is much less. And many times we prefer an SFO plan because even if there is some perturbation of the dose, you don't have too many uncertainties. But many a times, if the dose distribution is very complex, there is a critical structure very adjacent to it, like an optic chiasm or a brainstem or a rectum or in a child, we have to use akin to IMRT, inhomogeneous dose distribution. And that is called intensity modulated radiotherapy, proton therapy, or multi-field optimization. It's particularly done with Monte Carlo on a robust planning system. And when you combine these three fields, they will not individually cover the whole target. And you assign a particular unit, like an IMRT, and you can achieve very good data on it. And so we use both. Sometimes we use what is called hybrid plan. We use some part of the treatment you use with SFO and some part you use with MFO, depending upon site, depending upon the dose constraint, depending upon various patient and tumor factors. There is also this concept of biological dose distribution and the robust optimization. What could be the setup? Another, at the end of the Bragg peak, there is a bit of range uncertainty because the Bragg peak can vary a little bit, and the distribution and the RB is always not 1.1, it can be more. So we always try to do the plan where the end of the Bragg peak does not end on a particular critical organ. And that is very, very important. And that also comes with experience, with the learning curve, that how you plan your beams. And that is also called, we give less relevance to PTV, we call CTV based optimization. I can explain to you later in the question answer session. We have treated a number of prostate cancers, and prostate, especially when you have to treat the high risk prostate, where you have to treat the pelvic nodes, because significantly lesser dose to the bowel. But even in early prostate cancer, it can rival a SBRT plan or a CyberNAV plan, and the same can be delivered with proton with few fractions. We can go 1610, or we can use actually even 6 fractions nowadays. We have not started the ultra high fractionation, hypofractionation in prostate, but my colleague Dr. Srinivas is actively pursuing this program, and many centers in the world can achieve very good dose distribution. This is one of our own patients which treated with prostate cancer, especially, as I said, high risk prostate cancer gives a very good distribution. Esophagus, both in the radical setting or in the neoadjuvant setting where you have to give only 41.4 gray, can also be a very good dose distribution. The esophagus, there is an immunological angle to it as well, because when you treat a large beam like esophagus, the circulating blood, which can get irradiated with photon, can also irradiate a lot of lymphocytes. And with the advent of the benefit of radiation to spare the lymphocytes, to give immunological benefit angle to the tumor, the proton therapy has been postulated to reduce the irradiation to the T lymphocytes, can also confer to some extent not only the quality of life parameter, but also potentially a survival benefit. And this is being tested in many sites. We have also treated pancreas in difficult sites, both postoperative or in the radical site. And you have to be very careful in pancreas, of course, because you have to see the distal end of the proton does not end in duodenum or in the stomach wall. But with a bit of an experience that we can treat a relatively difficult, unresectable site / proton. I just want to tell you about the non-small cell lung cancer. We know the significance of Pacific trial using Durham how much benefit it has made. But we have also realized that there is a bit of increased pneumonitis, although there is an improvement in outcome in terms of survival, but it did come at a little bit of a cost. So the postulation is that maybe the pencil beam proton will contribute a little bit less to the pneumonitis, and this has to be seen to see. We have treated quite a few thoracic malignancies, both the mediastinal malignancies, thymomas, lymphomas, but also lung cancer. Those patients who can hold the breath, we have treated in breath hold. We have also tried to use the surface guidings as some kind of motion management. Of course, you have to choose your patients carefully. And this is one site where protons have to be very careful because they can stop. Some of the data in MD Anderson, for example, in lung was negative because vast majority, there was a learning curve. They used passive scattering. And with the modern proton therapy, which I showed you some of the technical advantages, the second generation trials, which are ongoing at the moment, are likely to be more in favor as compared to the previous trials. Many of us believe that in breast cancer also, it might make a difference, especially when you have to treat the left side of the breast, and also if you have to treat the internal memory, because there are number of lymph nodes there. And ASTRO, we know that the irradiated heart volume has to be minimized to the least possible site. We use surface guided radiotherapy for these tumors. It's a relatively simple plan. It can result in significant cardiac sparing, especially with pencil beam, and also significant sparing of the pulmonary toxicity, not to mention also the risk of opposite side radiation to the opposite side of breast, and also to the second cancer, which some of these EBCTC data showed significant proportion of them having second cancers in the lung, breast, and esophagus. So there is a fair deal of enthusiasm, including a randomized trial being done in the US. We have also embarked on the breast cancer program in our center. My colleague, Dr. Nangia, is leading, and many centers in the world are looking, especially, you have to choose your sites, especially in anatomies where there is a relatively high risk of radiation with photon irradiating different parts of the heart, exceeding those constraints, and this can be one attractive indication. Also, the bilateral breast cancer, where sometimes, we used to use this bilateral arc therapy with electrons, still some spillage and inhomogeneity would take place. But with modern way, you can use potentially the proton therapy using fixed fields. You can use on phase or the most 2 or 3 fields, which can result similar dose distribution as much better than the photon world. One of the other things which people ask us is the cost effectiveness. I'll take a minute on it. I know I'm almost close to the time. I think I should be finished in 2-3 minutes. The cost effectiveness of proton is the classic Markov model, where you put the initial investment and balance out with the benefit that the patients would yield to himself or herself, but also to the societal benefit in terms of preservation of the function, in terms of survival, in terms of employment, and contribution to the society. And this was done 4 years ago, published in Cancer from University of Maryland. They showed us that even with the previous proton beam therapy technology, although the initial investment was relatively high, in the long run, it was cost effective in pediatric cancers, brain tumors, well-selected breast cancer, loco-regionally non-small cell lung cancer, and head and neck cancers. And now I'm sure with the more technology and as the data gets more robust, the list is going to be more, many other sites will be included in the list. In our center, we are meticulously collecting prospective quality of life and patient-reported outcome data. This is just a very preliminary data to show you that the quality of life was same or improved in many of these tumors. Finally, I also want to bring in the immune modulation pathway. We know that there is a great deal of interest in synergizing the immune checkpoint blockade. We know that sometimes they may not benefit, they benefit only 30-40%, depending upon the different factors, and surgery, targeted therapies, chemotherapy, and now radiation therapy has been also implicated, what is called combinatorial approach, because it can recruit some of the T cells and make potentially a cold tumor, because it can trigger a lot of antigens and trigger the immune response, making a potentially cold tumor into a potentially hot tumor. And there's a fair degree of excitement. And what is interesting is the doses of radiation. It has been seen that a reasonably hypofractionated regimen, not too high dose, but not also the conventional, and especially with technology which has a high RB, such as carbon and proton, will be more immunogenic and therefore can elicit potentially more immune response. And this is a fascinating beam, which I am also particularly excited about. So proton can reduce the side effects to spare other T cells, for example, the thyroid, the thymus, the Waldear's ring, the other lymph node structures in the body. And also you can give high dose per fraction, and because of superior RB can potentially elicit better immunogenic response. And there are a number of trials going on in this direction. Hopefully some of these will be positive to show some benefit in these sites. We are collecting the data in our center very meticulously, both in the physics and also in various clinical points. Some of this data is already in the PubMed. You're welcome to see some of this data already. And finally, this is, I think, my final slide, that as a summary slide, I can say, while proton is not unequally proven, but we believe this is a significant advance in different clinical sites. It does have some amount of uncertainty you have to be careful about. There is a great deal of excitement and collaboration in different parts of the world using this technology. A number of clinical trials, in fact, I believe that it is even as equal or maybe more in some sites as compared to the photon, where the proton therapy in different platforms is being studied. You have to choose your patients carefully, as in any other cancer modality. You judiciously choose, and in many sites, as has been listed out in this slide, although the robust evidence is still in about 5 to 8 or 9% of the cancer cases, but it is believed that in the next decade or so, the percentage of patients which will likely to be eligible for the proton, and as I mentioned, using the modern proton, could be even as high as 20 to 25%. Only time will tell. And we are fortunate, as I mentioned, that in our country, we can say that at least we have this technology for our patients, and a number of other centers could take this up as well to be as a part to offer as a part of other multimodality therapies. So thank you very much for listening, and I'll be happy to take any questions if there might be.
Thank you, Dr. Jalali, for an excellent discourse on proton beam therapy. It started from the very basic to the most recent. Certainly clarified a lot of things that were there in my mind. We had asked for some questions, but apparently we haven't received any. Okay, so what immobilization devices are used for proton therapy? Sir, would you like to take this?
So immobilization devices are actually identical to what we use for the photon technology. There are some couple of differences though. The immobilization can be the usual thermoplastic mask that you use for head and neck or CNS. For the pelvis, either you can use the same, but we tend to use the vacuum locks, especially treating the spine. For other sides, you use the knee rest as you would use for the pelvis. The only point you have to make sure is that sometimes you have to see the entrance of the beam. And sometimes because of the proton, there can be slightly higher skin dose as compared to the photon. And that is very well known. So therefore, you have to be a little bit careful in customizing the immobilization device, number one. Number two, because the uncertainty is slightly more, so when you do the quality assurance scans, we do 3 to 4 to 5, depending upon case to case, especially in head and neck. Maybe you, we were ourselves surprised when we analyzed our data that 65% of our head and neck cancers actually had to undergo adaptive radiotherapy. We have to change the plan sometimes, and therefore you have to re-immobilize. So you choose the immobilization device accordingly, and you also see where the beams are coming from. So essentially similar to photon, but with a little bit extra precaution.
So the thermoplastic material does not per se cause any particular addition into the heterogeneity.
No perturbation. Is there any role for lymphoma? Absolutely. Lymphoma is a very good indication. There is a full-fledged paper which was published a couple of years ago, maybe last year, in the Red Journal about the guidelines in lymphomas as an IFRT, depending upon the site. Lymphoma again has a very high chance of cure and survival, and they sometimes are very young, but even in older people. I will tell you briefly about the geriatric population in a minute as well, since it was brought up. So they can significantly reduce the chances of adjacent radiation of the normal structures, whichever site. For example, mediastinum is very, very important. The cardiac structures can be significantly reduced. But even in head and neck sites, it can be a very good site to reduce the parotid dose, to the thyroid dose, and to the integral dose in general. Some of these lymphomas, as we know, receive lots of systemic therapy and also are at a risk of developing second cancers. So therefore, the proton therapy also has the benefit, as Dr. Sani in his questions, and also I tried to allude to, is an indication for reducing the integral dose and also gives a better cure rate. I did want to make a point on geriatric population. Now, we always say in proton, it is more important for the young patients and for the adolescents who have the long-term survival, what we have realized globally and also in our Indian population, some of the geriatric patients we have actually seen makes a difference, because sometimes, especially when you combine, say, head and neck cancer, when you combine systemic therapy, sometimes there are interruptions, they don't tolerate, mucositis is very high. We have realized because of the rapid dose fall off, especially to the other side of the oral cavity and mucosa, and also to the DARs now, for example, they can actually tolerate the treatment much better. And there is an increasing thrust on using this technology, because classically we were using for pediatric and adolescents and young people, but there is a other second peak, if I may say so, who could also potentially benefit from this technology.
So there is a question there's a question that, is there any change in guidelines for patients being treated by proton beam vis-a-vis the regular photon beam guidelines?
Yes, there are some change in the guidelines. I mentioned the lymphoma guidelines. There are some changes in the CNS guidelines, little bit. Essentially, there are two differences in the guidelines. One is when you do the contouring, for example, skin has to be, because it gives slightly more dose to the skin, whether it's a breast cancer or head and neck cancer, you have to be very careful to can subtract the skin, like we do sometimes even in photons.
Yes.
If you give a little lesser, bigger dose. So that is one part where the CTV can be transformed. The second point is actually in the evaluation process. In the contouring bit, as I mentioned briefly in passing, the PTV is losing its concept, what is called robust optimization. Because what we do is we make the worst case scenario and the best case scenario in the optimization engines with a degree of uncertainty of 3% dose to 3.5 millimeters. That is the general figure that we quote. And then you see the optimization engines, what you do, and it gives you the nominal dose, it gives you a robust optimized plan where you can prescribe the dose to the CTV rather than PTV. I still prefer taking into the, and that is the questions that was asked by Dr. Shagun Mishra as well. The factors which depend upon are, what is the site? For example, craniospinal radiation, very large field, you have to robustly optimize. If it is very close to the optic nerve or an optic chiasm, especially in a re-radiation, if it is close to a structure which can have electronic disequilibrium, for example, in the sinuses, a little bit change in the air or the air cavity or in the fluid cavity can perturb the dose significantly, where we put a lot of emphasis on robust optimization. In a craniopharyngioma, as many of you know, there can be a change in the fluid, cystic degeneration can take place. That's why we do sometimes weekly or twice, every second week we do the MRIs to see any change. So you do robust optimization in those sites. More or less in all our sites, we tend to do at least some form of robust optimization to overcome these issues. So these are the planning and contouring guidelines, and also a significant proportion needs adaptive. So these are some of they are not completely different, but this is mainly the fine tuning of the planning process, which actually you cannot learn so much in a paper or a textbook. Once you actually do it, then it makes a difference. There were two questions. One question is metal prosthesis. This is a brilliant question. And this comes to our point, and I should have actually mentioned it and thank the person who has asked this question, Dr. Mehta, I believe. Any hardware, anything, any density which can perturb the dose, we don't like in proton. So if there is any metal, for example, in the spine for stabilization, in a chordoma or in any tumor, we don't like it. Any mesh, if you put, even in the retroperitoneal sarcomas or in GI cancer surgery or skull-based surgery, we tend to put a tissue-specific. If it's a flap and everything, not a problem. But any metal, then if by chance you do have, then you have to see the density. The planning systems does allow us to incorporate that in the density material such that it can optimize it accordingly. but still you have to have a little bit of uncertainty. You tend to see as to how it is. And there are guidelines now. In fact, in our center also, we ask the surgeons to put it in such a way such that it can actually spare it the normal tissue to some extent. For example, a skull-based chordoma away from the brainstem. So in general, we don't like metal or any prosthesis too much, but it is not an absolute contraindication. It's a relative contraindication. The planning systems has the ability to incorporate the density into the optimization plan. Gagan, I noticed two or three more questions. Can you
Sir,
please repeat it to me?
okay. So Ajit Gandhi from Lucknow, Dr. Ajit is asking which sites would you advise not to go for proton therapy? And considering that the indications are ever expanding, is it going to overshadow photons eventually?
Okay. So there are some sites where you don't need proton therapy. I'll give you three or four examples. One example in my own field, brain, for example, you don't need in pontine, diffuse pontine glioma. There is hardly any evidence that it will make a difference. Their prognosis is not very good. The evidence for glioblastoma is building up. It is not an absolute indication. We can talk in a separate question. That is another indication one can perhaps thought. But a small spherical round tumor, for example, a brain metastasis, less than 2 to 3 centimeter. In fact, proton dosimetry sometimes can be worse. One of the not so good things proton as compared to photon is there is a slightly more lateral penumbra with proton as compared to the photon. So if you have a small, relatively spherical round tumor, you don't need actually a proton. You can achieve beautiful distribution for radiosurgery, for example, with a gamma knife or a cyber knife or a conventional LINAC. But whole brain radiotherapy, if you want to do sparing the hippocampus, which many people do now, maybe you also do now,
Yes.
there is evidence that because hippocampus is a slightly complex shape, the proton dosimetry is superior to achieve better hippocampal sparing as compared to photon. There is not so much difference, but there is some data to suggest, and we have also done. This is another site where you don't need some of the soft tissue tumors which are in the periphery. There is hardly anything to spare. There is not too much difference. Some people say that in very, very early cancers, like whether it is head and neck or prostate, the magnitude of difference may not be so much. In general, the larger the tumor, the larger the target volume, and more ipsilateral the target volume, better is the indication and magnitude of benefit of proton. Again, it is a myth. Some people think if it is a very early cancer and small cancer, the proton benefit will be very more. It doesn't mean proton will not work there. But surprising as it may sound, as the tumor stage and target volume slightly becomes more and more complex and very irregular shape, the magnitude of benefit becomes more.
So what is very clear is that as radiation oncologists, if we know what we need for our patient, we can choose,
The modality.
the modality.
Absolutely right.
Uh, a very nice paper you alluded to during the discourse about the dose to hippocampus and how the mean dose of 30.6 gray was coming out to be. So that made me think, although it's a little bit of a not so well-formed thought, that in that case, the whole brain radiation of 30 gray should not be that toxic to the hippocampus. Just your quick thoughts on this, sir.
Yeah, that is an interesting question. Should not be, but it is not only the hippocampus, you see. When you do whole brain, it is a myth that you focus only on hippocampus. The frontal lobes, the temporal lobe, the limbic system, even hypothalamic pituitary axis all play part in neurocognition. So when you do hippocampus, although the hippocampus dose you can achieve to the dose that you mentioned, but you are irradiating a lot of other organs. While when you give focal radiotherapy, there, at least that is the data that we have demonstrated, and in young patients, the age also becomes an important point. There, in partial brain radiation, therefore the dose constant is slightly on the higher side than one would believe.
But if we are going to do whole brain radiation, and then we are all inclined towards doing hippocampal sparing, so in the light of current data, should we really be because the hippocampus is getting the dose that is kind of permissible?
In a way, but as I mentioned, there are other organs, and although our data shows 30 gray, I would argue that still Alara principle goes. Hippocampus is an extremely sensitive organ. There is a constant neurogenesis taking place in that area post radiation. There is ample preclinical and clinical data. So as low as possible should be the dose constant for hippocampus.
And maybe when we are doing whole brain, we are doing 30 and 10, and this data is more from 54 and 30.
Absolutely.
So maybe that dose per fraction is making a lot.
Absolutely right. Absolutely right. That is also an important factor.
Sir, there's last question, which I guess you have answered in many ways. Should PTV margin be different as compared to classic 1 Herc? So
which I just mentioned, there is a PTV is losing more and more, even in our experience in the last now 1.5, 2 years. We are relying less and less on PTV. We are going CTV based optimization, depending upon the site. You can actually make differential robust optimization also. It need not be uniform in XYZ direction. You can choose different robust optimization engines. So although still conventionally we still take the PTV, but I think it will actually translate into photons also. Although currently more emphasis on proton, but robust optimization conceptually is applicable to even photons. So yes. I would imagine in the next decade, there will be less relevance of PTV in general and more relevance on CTV based optimization.
Yes, if we are as sensitive to the changes of our target as you are for your proton beam patients, then we would also find that the difference in the heterogeneity is a little more than what we should be looking at. Very, very, very deep point made, sir. So I can see Dr. Shubham is back. So he wants to stop the.
Yeah, it's too late for everyone. Sorry to keep everyone.
No, sir. I must say, I think. So I am more of a statistics man, and I was really intrigued by that paper which showed, the intellectual ability being maintained. So I was just wondering, how did they choose the baseline? How do you ensure that the group which was starting the conventional versus the photon therapy, how did they ensure that they were similar to begin with? And how did they? So it will be an interesting read, because this is something which you can't choose. I mean, for you to compare two things, you have to start from having comparable groups, and I don't know how did they think of this, but I'm sure it's an evolving process, and probably the APCC will come up with better data, and probably we will be witness to it. But thank you, sir. I think it was a very, very elusive presentation, and I'm again because I'm seeing the numbers, so just to document, and this is visually and verbally documenting, we had 100 participants. We were fully logged in the first 5 minutes of me letting people in, and we had another 50 concurrent people hearing you on YouTube as well. We'll keep a recording of this also. It should be available on our YouTube channel, so it remains there in the archive, sir. So people who want to refer it and can read through it and take out the important points that they want to create a short answer. That is what our aim is, that people like you who have been teachers, who have mentored students, can tell us what are important points for students to keep in mind when they're preparing a short answer, because these things are not available anywhere.
No.
Somebody would have to go through a review paper to pick up things, and even then they might not benefit from your presence at that time. So this is a good platform, and I think we have been helping students. So yeah, I think we are achieving what we are trying to achieve, and thank you again for being there for us. And it's 10 o'clock. I just had my dinner in the meantime when my video was off. So, but I'm sure you are famished. But if we can go to the answers, and I would want Dr. Jalali sir to stay till we give the answers. First, I would want to ask you, how did you find the questions to be? Because we every time ask the faculty, were they relevant? Were they? You think these were the questions that need to be asked, or would you want something different to be asked?
I mean, their questions were great. I compliment Gagan. Perhaps one or two questions could be more clinically oriented to, given the mixed audience that you have. They were absolutely perfect for a strictly radiation oncology community. But for a mixed audience, some of the sites could have been talked of, although there were many clinically relevant questions.
So I gave him the mandate for only 5 questions, and the 6th question that he mentioned was the clinical was the question. So I took that off. But may I request Dr. Geeta to come in and give us the statistics, how many answered and how many answered correct. In the meantime, I'll share my screen with the answers, and I want Dr. Gagan to read those answers out, because I will not make a head and tail of the options. So please, Dr. Gagan will read them out. And I'll share my screen. Dr. Geeta, you can please go ahead with the statistics in the meantime. Dr. Geeta, can you hear me?
Let me unmute myself.
Yeah. We can hear you.
Okay, so this time round, we had the highest number of participants in the quiz. So 28. So that's brilliant, considering that we had been stuck at 11 and 12 and 13. So this time we've almost doubled the number of participants. So I think I should wait for Gagan to, answer the questions, and then I will tell you as to how many got them right and how many did.
So can everybody see my screen?
Yes.
Okay, great. Dr. Gagan, you are on again.
Okay. So before I start with the answers, I must acknowledge my colleague Rashmi Shukla for helping me out with these questions. And then I'll also say the sixth question, the elusive sixth question. And so question number 1. So choose the correct answer. So this was a question very basic on physics. The answer is all of the above. These are all the basic properties of proton as a particle. Next, please. This is about the spread out Bragg peak. This was a basic concept of spread out Bragg peak. And the answer is 1. It's heteroenergetic beam. As Sir has explained, that multiple energies are thrown to cover the entire thickness of the target, like bread, the slices of bread, as he was talking about. Next question, please. Protons can be accelerated to high energy by using all of the above. So this is, these are all the tools to accelerate. So, I have nothing more to expand on this. All are correct about active proton beam modulation, except collimators and compensators are not required. So yes, the proton beam modulation, as Sir showed, it was very descriptive GIF, a moving image, which showed how the proton beam is actually a pencil beam which covers the various parts of the target. So collimators and compensators are not required. They are more required in spread out in the passive scattering proton beam. Sir, am I right here?
Yes, absolutely.
So this is the question number 5. Select the false statement about the clinical use of proton beam. So the first is high degree of conformality with passive scattering proton beam. Basically, while proton beam is very, very conformal, but a high degree of conformality is not achievable with passive scattering proton beam, and it's more possible with pencil beam scanning. These are clinical questions. Of course, these are not mathematical questions that they can be a very clear right and wrong, but this is the perspective of this question. So, so question number 6 is, what is the gold standard treatment for ocular melanoma? And this was the clinical question that had been put in. So the answer is proton beam therapy. So just as so many things were discussed and their relative nuances were discussed, for an ocular melanoma where you are surrounded by all the critical structures there can be, proton beam therapy perhaps will really benefit the patient, and that is what is the gold standard as of now. So, so this is the end of my question answer discussion.
Dr. Geeta.
Okay, so I'm back, and so like I said, 28 people, but amongst the 28, we have only one person who got all the 5 answers right, and that is Dr. Sudarshan Gupta from CMC Vellore.
Wow.
So applause for Dr. Sudarshan Gupta. But then we had 9 others who got 4 of them right, which is not bad at all. So Dr. Akhila from HCG, Dr. Rashmi, I don't know, she's not mentioned her institute, Dr. Bharat Nandu from Hinduja, Dr. Alvina Vadaseri from Tata Memorial, Dr. Riddhi Jyoti Talukdar from Apollo, Kolkata, Dr. Divya from KGMU, Dr. Akanksha Anup, I don't know her institute, Dr. Karishma, I believe that's her name because it just said KR, there was no description to her, and Dr. Sujit Shukla from VMMC, Safdarjung Hospital. So they were the ones who were close, but then the top prize goes to Dr. Sudarshan Gupta from CMC Vellore. Thank you, Dr. Jalali. Always a pleasure to listen to you. You're a great teacher, and I think we also learn in the process because I don't think I would make the effort to go through proton therapy otherwise, but hearing it from you, it sounds also a brilliant, great technology, and I'm sure there will be more centers and more people benefiting from it in the future. Thank you so much for joining us.
Thank you.
Dr. Shubham and Dr. Geeta, sorry, just wanted to just say one line.
Yeah.
On 17th of July, there is an opportunity to listen to Dr. Jalali again, talking about the WHO 2016 classification in brain tumors, and that will be a separate webinar. And whoever is interested, eventually it will be floated in the common WhatsApp groups, and you will get the link.
Sure.
Please
Thank you, Gagan. Thank you, Gagan. So this is our next upcoming webinar with Dr. Arvind Krishnamurthy, who's the head of department from ADR Institute, surgical oncologist, talking on the current status and future preventive strategies in HPV-related cancers. His mandate is to speak on basically HPV, talk about the vaccination strategies, talking about the virus structure, talking about the subtypes, so the whole gamut of HPV. And our aim is to create. The topic is not on cervical cancer. The topic is not on oral cancers, but HPV as such. Okay, so it will be used for all our medical, radiation, surgical colleagues. So we will see you that time. Thank you so much. Thank you, Dr. Jalali. Thank you, Dr. Gagan. Thank you, Dr. Geeta. Good night, everybody. Good night.
Good night.
Thank you very much.
Thank you.
Bye bye.
Bye bye.